Good morning. When Dr. Banderi asked me to give a talk today, I thought, well, I'm not going to talk about boring cardiac surgery procedures, and I thought that I should talk about my 20 years or so career in research, which has been a roller coaster career. I got the good, the bad, the ugly, and sometimes the kinky. I tamed down my presentation because I know some ladies are blushing and recognize the artwork on that slide, but I tamed it down, don't worry. It started, so I trained in Quebec City. I'm French Canadian. And my wife and I left, we were 26, 27 years old, and realized actually we couldn't speak English. So actually I remember that, those years were the years that the big trials were coming out of the NIH, breast cancer trial, colorectal trials. And I remember that, well, I couldn't speak English, but also I couldn't read these trials. And somehow we ended up in Vancouver. Dr. Rich Finlay was the program director, the director of surgery. And he said, Andre, did you survive the first night in ICU? Could you speak English? I said, yeah, well, that's good enough. Now you can be in the program. So thank you. So, and that was the way in those days. So I was with Gary Gelfand, who was a thoracic surgeon in Calgary. Actually, both of us probably making a lot of trouble for him because after a few years, he said, well, why don't you two guys go to UBC and do a master's degree in clinical epidemiology? So I guess a good way to get rid of us, but he was very good, actually. He was ahead of his time, and he actually provided salary support. That was at the end of our training. He paid us on one more year of training, and we went there and got our degrees. And my thesis was actually in cost effectiveness of lung transplantation. I was supposed to be a lung transplant surgeon going back to Quebec City. And when the Minister of Health in Quebec decided that, well, he changed his mind and my job disappeared, I basically ended up here in McMaster. And Dr. Schrag, who passed away a few years ago, was doing my interview and said, Andre, do you know anything about these new economic things? I said, yes, I did my thesis on that. And then I got the job, and here I am. So I started my research right away. It was in July 1996. And for the new staff, don't wait 6 or 12 months to get good in clinics. Start right away because, yeah, you can do both at the same time when you start. You're not going to be that busy initially. And again, don't wait to be clinically established. And your negotiation power, as Sheila mentioned, mine was very short. It was basically a few weeks. And after that, well, we were just too busy. So you have negotiation power, it's limited. And what I got is actually got 2 of these babies. That's what I got. So this is a 386 Windows machine running Pentium. And I got 16 megabytes of RAM and 300 megabytes of hard drive. Now we all realize today that all of us have 100, 500, 1,000 times more computing power in this iPhone than these little things. But nevertheless, you need a mentor. Okay, there's no way you can survive without somebody telling you what to do, how to do it. And a mentor that can actually give you cash or money or staff. And in cardiac surgery, there was basically no much research, and I couldn't find a mentor. And I ended up with seeing Jack Hirsch. And it was a great moment. He said, Andre, I don't need you. My career is established. Yes, he's Jack Hirsch. He said, but anyway, I think I want you to be successful. So actually, he gave me salary for 6 months for a research nurse. He said, I'll pay her for 6 months. After that, you're on your own. I said, thank you very much. And on my own, here I went. So I started the Cadence group, so it stands for cardiac disease and economic analysis and clinical evaluation. So my 2 interests. And there was a database, it still exists, it's the Cardiac Care Network of Ontario, actually having a database of cardiac surgery patients when the demographics, the usual variables are recorded. And that data was not accessible, but however, the printout copy was accessible to me. And what I did is I got all these copies from that nurse who was running that program, and I re-enter all that data in my own database that I set up there. And over the years, I run that database actually for 10 years. It cost me a lot of money, but it basically started there in my research. And also, I started to be interested in clinical trials in the industry. And basically, nobody was doing that in my group at that time. And and got involved into this. And I got also involved in my first interest of economic analysis. And within 5 years, Cadence, we did very well. Actually, we grew to a group of about 10 people. And we did some of the work there. So we did economic analysis, the famous HOPE study, CURE study. Clinical trials started with collaborating with groups like the Stitch from the NIH, Expedition, Primal, they were all industries, started to do all sort of things and collaborating and working with these people. But also, I started to do my own stuff, because that's basically the interest there. I started from nothing, but I wanted to do my own stuff. And one of the first paper we did was actually looking at it was a research master degree student here, looking at the outcomes of octogenarians in cardiac surgery. Now, in the late 90s, nobody, or virtually nobody, was doing cardiac surgery in these patients. And we look at the costs and outcomes, it's actually very good, and we published in CMAJ. It had a huge impact on the country, because now we're doing, I would say, a third of our population of patients are octogenarians, and they're doing very well. But also, I got interested in the off-pump, of a beating heart technique of doing cardiac surgery. And with Farouk Faroukiar, that's now in the department. So Farouk was working with me at that time. And we did something so simple. So basically, it was the interest of all the surgeons in the industry and so on. So I took a little bit of money from the industry, and I went to CIHR and I said, I want to do a registry. So we planned a registry about 3,000 patients. We did 1,600 patients around the country that were off-pump, and compared that to about 1,700 patients for our own institution. We were all on-pump, because we're not doing off-pump at that time. And we went to the CIHR with a badly written grant. It was not an RCT. It was not even a good prospective study. And one of the reviewers said, well, the protocol is not very good, but for $30,000 they're asking, that's probably the best money that CIHR could invest. And he was right about that. I'll show you why. So there we go. However, it started to turn sour. The bad stuff is coming around about 10, 12 years ago. One of the success, and Dr. Hurd believed that, one of the success of Hamilton, why research grew so well in Hamilton, was actually the overall costs to do research were low at 15%. And we catch up at that time, we went to 33%. And it had a huge impact on my research, because basically I lost my margin, call that revenue. But you know, when you have salaries up to $300,000 a year of salary, you need to be careful about your budget. So I lost my margin there, and gradually had to reduce my staff. And one day I'm bankrupt. Tell you why. In those days, the accounting for research was not very good. And my research manager then, Roseanne Kent, keep telling me, something's wrong with the numbers. We have too much money in the account. And the way it worked, actually, it was very, very difficult. You had to go on a website from the hospital into the accounting system, and there was a box, it was a secret box. You had to click on the secret box to have access to your data. Very complicated. And one day I got a phone call. They said, Dr. Lamy, last year we did a fundraising. They're still doing it every year, the research fundraising thing. And we raised about $250,000, and we lost it. We couldn't find the money. But yesterday we found it. It's in your account. So a year later, they found the money because somebody punched in the wrong number. So by the way, you now owe us $200,000. Thank you very much. That's when you're proud to be French, so you can express yourself in many chosen words that don't really exist in English. So there I go, my first bankruptcy. I'm sorry to provoke people here, but yes, hospital and university, they're kind of sucking money out of the researcher. We are the golden goose. And we bring all this money from granting agencies, from industry, from all over the world. I mean, I collaborate with people from all over the world. We bring that money in to bring new jobs, new research into Hamilton, and people are fighting to give between them to get our money out of it. And it's very difficult for us. That's how I feel most of the time. But nevertheless, we did great work. We were in the red, but we worked like crazy, nurses and the rest of the team, and we did a lot of economic analysis. We tend to pay fairly well. We also did a lot of clinical trials. The TME is a big group, similar to PHRI. And I did a lot of research with them, research with group in Australia, industry, so on and so forth. We're very active, possibly too active. But I started coronary, and vision cardiac, we're now running, but mostly coronary about 5 years ago, and I'll talk a bit about that. So coronary, so it started from a computer and a database. I showed you the computer, and I told you about the database. It started from that. Then we did a comparative analysis with Farouk. So Farouk did this analysis, comparing adjusting for the true group and comparing them. And actually, the results we got from that analysis were actually pretty close to the randomized trial. And from that, we went to the CIHR, and we got a large RCT. So unless somebody can tell me I'm wrong, I think it's still the largest surgical trial completed and published. And we got, as you see, almost $7 million from CIHR. I'm certainly happy with that. And we randomized 4,752 patients, 19 countries, 79 sites around the world. It was very interesting to work with all these people, all surgeons like you and I that are interested in research. But what's most interesting part is actually we're comparing two surgical techniques, and it's very rare we do that. Like we don't compare surgery versus stent or surgery versus medication or this medication or that. It was surgeons against surgeon, technique against techniques. And what we took from Dr. Bandari and PJ Devro was actually if you use expertise-based randomization. So you be sure that the surgeons who are in the trial are either expert in both techniques or can share patients. So if one surgeon is expert in one and what the other guy is expert in the other technique, they can actually share patients. So when you do the trials, the level of expertise for both techniques is very high. It is crucial if you do a comparison of a technique that has a longer learning curve. Unfortunately, the ugly has hit now. So, well, yes, the overhead is still at 33%. But the zombie of the zombie, the ugliest beast in the world is called bureaucracy of regulatory agencies and pharma. And that pushed me into bankruptcy again. Because we were working so hard to get all these trials, get the money, or money back, you know, that $200,000. We were working hard. We made it actually in the black for a while. And then as the bureaucracy step into this, slow down the process. You want to start a study in 3 months? Now it's 6, 9 months, sometime a year. And this is how I feel now, okay? So Health Canada is squeezing me one way, the pharma is squeezing me the other way, and I'm stuck in there, and my money is going away. Paperwork. I understand that, regulations are important, no doubt about that. Patients have to be protected, well protected in research, there's no doubt about that. But before you are simple, more obvious, clear. Like you can put a patient in the trial, have a consent form explaining the trial to the patient would be 4 or 5 pages. Now I do trials and the consent form is 22 pages. How can you do that? It's impossible. All of you upgraded those of you who have Apple. By the way, Apple is supposed to have a sale today, once a year. It's their Black Friday sale. But when you upgraded to iOS 8, how many of you scrolled down and read the whole blah, blah, blah pages of legalese? No, we don't do that. We just click, yeah, I agree. Yeah, I agree. Then you click, then you go. Well, how do we do that? How can we convince patients to read 22 pages? Impossible. So what they do, they actually trust us. So that's been like that since the beginning. They listen to us, they ask questions, they trust us, and they say, yes, I want to be part of your study. Go to your bank, get a mortgage, and try to read the fine print of the mortgage, and ask the banker to explain that to you. You'll never get your mortgage. He will kick you out. But now they force us to do that in research, and it doesn't make sense. Also, it's getting so bad that I'm doing a study right now helping Salim and the team at PHRI called Compass. It's a new blood thinner. We're looking at small dose of blood thinners to improve graft patency. Nice trial, very brilliant. And all over the world. So last week, I got a copy of a patient in China that had some bleeding from his hemorrhoids, and he's part of the trial. So I receive a copy of that. I have to read what happened to that poor patient. I have to send it to my RAB that we have here. And then I have to send it again to the study people to say, yes, I indeed read it and send it to the RAB. It doesn't make sense. There's no way for me to understand if, I don't even know which medication that patient received. It just doesn't make sense. We're dying in bureaucracy. At least this is clinical trials. Probably easier in the lab, I don't know. So, and now, well, I'm surviving, barely back in the black. I'm selecting my trials very carefully. Unfortunately, now it's a minimal staff. Unfortunately, now to let my research nurses go, $125,000 a year, including the benefits. Well, so I had to let them go. And now I have research assistant. They have a master's degree, bright kids, they're very good. And one thing we learned is actually to share. So before we were in silos, even in PHR, we're in silos, my nurses, your staff. Now we just share. So if we need a research nurse, we bring the research nurse from one study to the other. We learn to share because of that. And now I keep one eye on my grants, and the other eye, for sure, it's my research account. Now the system has changed. It's going to be actually easier for us to keep track of that. What about the kinky? Well, there's some kinky stuff in doing research. And for a researcher, no, it's not what you think, but for a researcher, it's actually, I'm talking clinical research, big trials. The real kink is actually to present your results at the large meetings around the world. And with coronary, I had the chance to present at the ECC in Chicago in March 2012. And basically, you're presenting in a room that it's probably 25 times the size of this room. There's thousands of people in the room. This screen like this, you have 3 screens. It's huge. And you spend a few days before that giving interviews because all is embargo. So all the interviews are done before with all these medical media outlets. And it's a great thing to do. And you enjoy that immensely. So we did that. And I presented at the ECC in 2012. So it took me 10 years of work to get there. And the year after, we did it again. And actually, we got lucky. So sometimes you work hard, sometimes you get lucky. There was, we decided to do the 1-year result. That was unexpected. It was an interim analysis that we did because other trials came out, and we wanted to bring our data to the discussion. And the ECC agreed to let me present. And the good thing is that when you do that at these big meetings, if you prepare your paper before, you can actually get it in New England quite easily. Well, it's easily, but you can get it in New England. And what's happening is that these big meetings and these big journals, they're also looking for stuff to publish, right? They want to be right there at the top. So if you're ready, if you have a good paper and your science is right on, they will take you. And the second time in 2013, we get in right on, and we were lucky. So that's the kink for research. And also, you get, I mean, that's in New England. I've published in many other journals and other medium. And, you know, some are more interesting than others. Some are higher quality than others. But there's always few of lower quality, but nevertheless, it's bottom right, people. Sorry, bottom right. So, and even that, sometimes you get even worse, and it's even more smutty. But yeah, again, please, bottom right. And you get in these places. But so it's clinical. Clinical research. I don't know about lab research. I have no knowledge. But in clinical research, the feeling is worldwide as clinical research is dying slowly. There's lack of funds for the granting agency. The CIHR don't have any funds. They reinvent themselves, but they don't know exactly where they're going to go, except they have less money than before. The poor researcher is being bled more and more because now I have to pay for my phone line, I have to pay for my fax line, I have to pay for all the tests, I have to pay for everything. And actually, when they moved me, they said, well, you can have the closets over there. And I said, well, who's going to pay for renovations? They said, well, doctor, you have to pay for it. So I paid for it, and actually I framed the bill on the door. So the next guy who wants to get my place will have to pay for it. But and the pharma is slowing down also. I mean, these big companies used to make double-digit profits over the years. Their profits now are single digit. They're going down. They're merging. Their pipeline is getting bare now. The big pharma is in trouble. I don't really care, but the rich people, they can take care of themselves. But the bureaucracy is accelerating very quickly, and that's the problem. So what can we do? Well, we can reduce bureaucracy and reduce the red tape and this, but I believe we need a central REB for these large trials, not local trials, but for these large multinational, multi-sites trials. We should have a central REB for the whole country. We can actually have an expert panel that can look at these trials and follow up all these events during the trial to know that, well, if the trial is doing well, we should carry on, or something's wrong, there's a signal, we should pause and look into this carefully. Same thing for the researchers. We should have a central agency for researchers. When you're in there, you're in and you're good. Do we need to do training for that? Absolutely. We need to be good. You need to be certified. No doubt about that. But what you have to do the same process 5 to 10 times a year when I need to apply for something. And please, CIHR, please stop changing your CV format every year. Please. In less overheads, I can only pray. I pray. But we have to reinvent ourselves. No doubt about it. And I think in surgery, actually, we're in good position for that. Because the surgical research is not dependent on pharma as much as cardiology or medicine. There's no, I guess there's no big profits, but no, the surgeon's always been oriented toward outcomes and costs. So the surgeon's always well aware of that. So we have a good chance for that. We're in better position than medicine, I would say. There's also a lot of comparative research that's going on in the States, and that's coming to us. In terms, the knowledge translation of what we are doing, and the surgeon are very well positioned. You show that they're very well positioned to do serious and high quality research on that. And my advice, and don't do it alone. Don't stay alone. You need to join a large group, or you need to collaborate. Okay, that's the fun part of research, is to collaborate. I'm running cardiac vision, and one day there's a guy from the School of Nursing came to see me. He's Mike McGillian, brilliant guy. He said, can I be part of your study, because I would like to do a sub-study looking at chronic pain in cardiac surgery. I said, my patient don't have any pain in cardiac surgery, but yes, I'm happy. So the guy, you just couldn't believe it. You let me in? Absolutely, come in, it's fun. And the guy's brilliant. He actually got money on his own, and now the study is stronger and better. So collaborate. And the last thing is that there are lots of important questions out there that need to be answered, and you have to answer them. So it's been a roller coaster for all these years, but don't get discouraged. Just get focused and answer these very important questions. I'd like to thank my family who supported me, or suffered me, I don't know, but for all these are my staff. Thank you.